The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, or the U.S. government. Hello! Welcome to the Childhood Lead Poisoning Prevention Training Module 2, Strategic Planning and Implementation of the 4 Key Strategies of a Lead Prevention Program and Evaluating its Impact. Today, we'll be reviewing Segment 3, Key Strategy, Linkage to Services. There are images featuring a father with a young daughter in his lap, a picture of a mother and child at the doctor's office, and a classroom with diverse students. There is an image of the Centers for Disease Control and Prevention logo, which also shows that CDC is a part of the Department of Health and Human Services. The purpose of this module is to introduce CDC's strategic priorities and outline proactive steps that can be taken to aid in the elimination of childhood lead exposure. This segment is designed to assist trainees in identifying children with blood lead levels above the reference value, which require follow-up and establishing partnerships with medical, environmental, and social service organizations that provide services to children with blood lead levels above the reference value. The CDC defines case management as coordinating, providing, and overseeing the services required to reduce blood lead levels below the reference value. Case management is not simply referring a child to other services or contacting the caregiver by telephone. Ongoing communication with the case management team, including caregivers and other service providers, and a cooperative approach to problem solving is essential to overcome the barriers interrupting efforts to decrease the child's blood lead level. There are 8 components of case management identified by CDC: client identification and outreach, individual assessment and diagnosis, service planning and resource identification, linking clients to needed services, service implementation and coordination, monitoring service delivery, advocacy, and evaluation. The CDC recommends certain actions based on blood lead level. The current CDC blood lead reference value is 3.5 micrograms per deciliter. The standard of care for children with higher blood lead levels includes nutritional and developmental assessments. If the child's blood lead level increases or if their blood lead level exceeds jurisdictional benchmarks, a neurodevelopmental assessment should also be completed. The case manager is responsible for overseeing the actions of the case management team, as previously mentioned, even if the case manager is not the responsible team member completing the direct service. A chart showing blood lead levels and actions recommended by CDC. Essential resources for children with higher blood lead levels include those given through the provider community, which is the hospital system, mental and behavioral health, and nutrition services, especially the Women, Infants, and Children Supplemental Nutrition Program, also known as WIC. Nutrition counseling and support is important to assist the caregiver in identifying how the child's diet can be improved or changed based on the current recommendations to support the elimination of lead. Children who qualify for WIC should be referred if they are not already enrolled. Managed care plans are also essential to coordinate additional care, assist with transportation, follow-up testing, and children's special healthcare services if the child has received chelation therapy. In addition to support through the provider, community housing through the United States Department of Health and Urban Development, or HUD, Lead Hazard Control Program is essential for lead remediation. Other relief programs can assist if relocation is needed during that time. Children with higher blood lead levels may need additional support through the education system, especially if developmental delays are noted either through the case manager or through the primary care provider. Several programs can assist the child and family to be prepared for school through the local Head Start programs or Great Start Readiness programs. In addition to education, parent support is essential. You may find this support through Child Protective Services or any prevention service organization, especially local parent advocacy or support groups. The case management team may consist of several different healthcare and other professionals, depending on the needs of your community and available resources. The child's caregiver and the child's primary care provider should also be included in the case management team to ensure continuity of care. Local public health agency involvement is also necessary to engage due to their core public health functions of assessment, policy development, and quality assurance. They also initiate and implement laws and regulations to assist in childhood lead poisoning elimination. This is an example of Michigan's Lead Safe Home program, which is funded through HUD. Their Lead Hazard Control Grant Program enables state or local agencies to provide grants or loans to property owners for conducting lead hazard control measures in low-income housing. These are different variations in case management teams. Alabama uses social workers to provide their case management services. In Iowa, they use nurses. However, they do not begin case management services until the child has a lead level of 15 micrograms per deciliter, at which an environmental investigation is also initiated. In Michigan, nurses should provide case management once a child has a blood lead level of 3.5 micrograms per deciliter, and some local entities will use community health workers to support the nurses. In New Jersey, the nurses complete their home visits with environmental investigators. Speaking of community health workers, who are they? Community health workers usually live in or work in the community they serve, enabling them to better assist with advancing health equity. Community health workers can excel in helping provide underserved populations with greater access to healthcare through culturally appropriate community health education. This is an example of how case management in Detroit, Michigan works with nurses and community health workers working together. If a case is referred to the local health department, the nurse case manager will contact the family of the child and offer services. Typically, the nurse is going to prioritize the children with higher blood lead levels due to capacity. The nurse will offer home visits, as well as care coordination with the primary care provider and developmental and behavioral programs as needed. Those can include Early On, an early intervention program in Michigan for infants and toddlers, safe housing, as well as social support. Once the nurse has done that initial assessment and provided care coordination, the community health worker will then follow up with the family and provide additional education, which can include lead-safe cleaning. They can also assist the family with the lead-safe home program application and finally, link the family to the parent advocacy group in Detroit. Cross-cultural communication when providing community services is essential. Understanding the culture of your community is crucial to advance efforts of lead poisoning elimination. The RESPECT model is a tool case managers may use to meet the clients and caregivers where they are, better understand their perceived needs, and ensure the interventions provided are appropriate. There are 7 components of the RESPECT model. The first, rapport, helps you see the patient's point of view. Empathy involves verbally acknowledging and legitimizing the patient's feelings. Support looks like helping the caregiver overcome barriers. Partnership is working with the caregiver and being flexible. Explanations is providing an explanation, checking often with the caregiver for understanding, and clarifying when needed. Cultural competence is respecting the caregiver's cultural beliefs and being aware of your own cultural biases and preconceptions. It's also knowing your limitations and addressing health issues across cultures and understanding your personal style and recognizing when it may not be working with certain caregivers or clients. And trust. Trust is extremely important and may take a while to build with each caregiver and client. Building trust is recognizing that self-disclosure may be difficult for some clients and caregivers. Therefore, you continue to consciously work to establish trust. Supporting a case management team can often look a little unbalanced. The job demands may outweigh the job resources. During implementation of case management, identify ways that you can decrease job demands through limiting paperwork, potentially building additional capacity for caseload management, and really working through what types of resources are essential for families in your community, as well as creating a safe environment within the workplace. Some job resources that would be helpful for each of the case managers would be identifying their own individual coping strategies and self-care mechanisms, ensuring that the supervisors are well equipped to provide support. In Detroit, we worked with the case management team, and we worked with a reflective supervision consultant who provided this service to us and allowed the team to debrief on specific cases, as well as review our own coping strategies so we left work at work. As a reminder, as of 2022, the current CDC's blood lead reference value is 3.5 micrograms per deciliter. There is a potential for that to change in the future. The state of Michigan is still working with partners to identify the timeline for implementing the updated reference value change and provide recommendations to local health departments as well as providers. However, currently the state of Michigan is using the reference value of 4.5 micrograms per deciliter. Once you have your team put together, you can finally initiate and implement your program based on the CDC guidance. This is how Michigan state and local response is built to address children with higher blood lead levels. So, as I mentioned, as a result of the CDC guidance, Michigan put these recommendations in place and their case management triggers and steps that the local health departments, providers, as well as the Michigan Department of Health and Human Services are responsible for in the case management of children with blood lead levels above the reference value. MDHHS is working with partners to identify a timeframe for implementing the reference value change and provide recommendations currently. As it stands, local health departments provide nursing case management, home visits for children with a blood lead level of 4.5 micrograms per deciliter and higher. We do round the 4.5 to 5 micrograms per deciliter. And those nurses work closely with the Lead Safe Home program to ensure a lead inspection is completed and that the residence is in the pipeline for abatement services if the applicant qualifies. The nurses are coordinating with the primary care providers to assure the child is scheduled for repeat testing based on CDC recommendations. If the parent declines case management services, the child moves out of the jurisdiction, or the blood lead level falls below the reference value, the case will then be closed, and the provider will be updated with all interventions completed. Children with a blood lead level of 45 micrograms per deciliter and above are referred to the hospital and evaluated for chelation. The nurses work with several community partners, the Lead Safe Home program, hospital system, and primary care provider to ensure children receiving chelation are not discharged to a home with lead hazards and that the hazards are abated and cleared before the child returns. Here's a closer look at the components of local health nurse case management in Michigan. Nurses are currently reimbursed for up to 6 visits through Medicaid. The Children's Special Healthcare Services model for reimbursement is used. The level of effort to contact the family should include, at a minimum, at least 2 telephone calls and 1 drop-by at the last known address, preferably one in non-business hours, plus a request to the child's primary care provider and/or the Medicaid health plan to assist in reaching the family. The frequency of visits is based upon in-home risk assessment findings, potential source of exposure, and the family's needs. Education provided by the nurse includes follow-up testing recommendations, incorporating more foods with vitamin D, calcium, and iron, lead-safe cleaning techniques, and identifying potential sources of exposure upon a visual assessment of the residents. The nurses will also use the environmental investigation report to educate caregivers on the identified hazards. And the nurse assessment is an overview of the child's health, development, behavioral concerns, and environment. The nurse must also initiate the plan of care for the child to document all of the provided interventions, including linkages to care and other referrals. As you can see, this again is Michigan state and local response to children with blood lead tests above the reference value. The local health departments do work closely with the provider community and MDHHS. The Lead Safe Home program under MDHHS sends an application to households of children with a lead level above the reference value, along with the MDHHS Childhood Lead Poisoning Prevention Program educational materials. CLIP and the Lead Safe Home program work closely with local health to ensure children hospitalized and receiving chelation are evaluated and an environmental investigation is completed. Lastly, here's a case study of a 12-month-old with exposure to lead to wrap up the module and provide an example of how case management can be effective in decreasing blood lead levels in children. The local health department received a referral for a child with a lead level of 20 micrograms per deciliter from the local pediatrician. The child was tested at his 12-month-old well-child visit. During the initial home visit assessment, the nurse case manager identified that the child's primary residence was built in 1941. Paint chips are visible around the perimeter of the home and wooden windows found throughout. The father of the child works in construction and the mother of the child is pregnant. A graphic of a mother holding a baby. So the child was referred to the local health department on November 12, 2020. On the same day, the community health worker provided education, referred the property for an environmental investigation, and provided the Lead Safe Home application. The nurse case manager completed the initial assessment on November 17, 2020, and by November 30, 2020, the environmental investigation was completed. The Lead Safe Home application was then submitted, and by this time, the child's lead level had decreased from 20 micrograms per deciliter to 11 micrograms per deciliter. Unfortunately, the application was returned due to missing information. The landlord was cooperative and resubmitted the application. By May, the application was in the approval process. The nurse, community health worker, and environmental investigator were successful in providing education to the caregiver, identifying the source of exposure, and providing additional linkage to care as needed. This case provides a great example of how case management and the CDC recommended actions based on lead level should be implemented to decrease exposure and link children with blood lead levels above the reference value to appropriate resources. A timeline showing the events of a case study on a 12-month-old child with exposure to lead from November 2020 to May 2021. In summary, this module highlighted the essential components of linkage to care. These include building a case management team supportive of the community needs, ensuring that appropriate support for case management staff and essential resources for children with a blood lead level above the reference value are accessible. This helps with staff retention and quality engagement of families enrolled in services. Cultural awareness and cultural competency are essential in order to build trust. A special thank you to the following programs for providing information, including Michigan, Alabama, New Jersey, and Iowa. Listed here are resources for you to access and review, and the acknowledgement and disclaimer. DLED, Center for Urban Studies, wayne.edu. Early Intervention Contact Information by State, CDC. Get twice the fruits and veggies with Double Up Food Bucks. DUFB, doubleupamerica.org. Home for SER National, ser-national.org. McKinney-Vento, National Center for Homeless Education. MDHHS, Family Preservation Program, michigan.gov. MICHWA, Michigan Community Health Worker Alliance. State SNAP Ed Programs, SNAP-Ed, USDA.gov. This presentation was developed in collaboration with the American Academy of Pediatrics and Amy Surma, MSN, BSN, a nurse consultant for the Childhood Lead Poisoning Prevention Program with the Michigan Department of Health and Human Services. The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the American Academy of Pediatrics, the U.S. Department of Health and Human Services, or the U.S. government. Thank you for viewing Module 2, Segment 3. For questions or comments regarding this segment, please send an email to leadinfo@cdc.gov and indicate Training Question Module 2, Segment 3 in the subject line.